here's the plan for today. I'll probably teach till whenever I get all the stuff done. Sorry I'm sitting down. It's the best I got. I'm not gonna stand up today. Police is here to make sure that I don't stand up because Miss Katniss made her come up here. And then you're gonna do the benchmark that we were supposed to do yesterday. We'll do that this afternoon. So that's the plan for today. So this Kahoot is on cancer. So the first 9 questions are all true-false questions on, and this is, not true-false, I'm sorry. It's either benign or malignant. So I'm going to give you a characteristic of a tumor, and you're going to tell me, is this a characteristic of a benign tumor or of a malignant tumor? Because we need to know how to differentiate all the different things of benign and malignant. So first 9 questions, and I don't swap it up, so benign's going to stay the same color, malignant's going to stay the same color. So a benign tumor has cells that pretty much look like the same cells of the cells that's around. Like if you have a benign liver tumor, the cells are going to look like liver cells. They've just mutated a little bit. If you have a malignant liver tumor, those cells are going to look completely different. So, very good. Next question. So a benign tumor, if you want to think of a benign tumor like an avocado seed, like it usually is a little round, encapsulated, small, and then it grows by just getting bigger. So malignancies are the ones that have all the spindly legs and grow out in odd shapes. So a benign tumor is more like an avocado seed. In fact, one of the brain surgeons that I used to work with, there's a benign brain tumor that he would have to get out, and he said literally that's what it felt like. Open up the skull and just pop it right out. As opposed to the malignancy tumors that take a lot more invasive surgeries, and you have to go in and kind of see where all it's going to, see how far it's spread in each direction. So benign tumors, avocado seeds. Malignant tumors, more like spiders with lots of legs. Very good job. So benign tumors typically grow very slowly, whereas malignancies can grow slow or they can grow very fast. So it depends on their blood supply, it depends on how much nutrients they're getting fed, if it's hormone driven or non-hormone driven. So there's a lot of different things that tell malignancies whether to grow fast or grow slow. But typically benign tumors always grow slow. Like it takes a while for that avocado seed to get kind of bigger. Very good job. So those little spider legs can definitely get into the lymphatic system and into the bloodstream. Good job. So benign tumors, again, they're encapsulated. They're in one location. They usually don't cause any other types of generalized effects. Whereas malignancies, we've already said they get into the lymphatic system, they get into the bloodstream. They've got little spidery legs that crawl all around. They cause a lot of generalized cancer effects. So when we think generalized cancer effects, what do you think of as like a generalized cancer problem? Weight loss, fatigue, I heard fatigue. Can cause some generalized pain. A lot of the pain does stem from where it's at because it starts pushing on, those little spidery legs start pushing on other structures. So it can start causing a lot of pain. Night sweats is another big one. So just those kind of overall cancer symptoms is what we're talking about when we're saying generalized effects. A lot of times you'll hear those called secondary cancer effects. The primary cancer effects are where it's at. Like if you have a liver tumor, your primary effects would be how your liver is affected, whereas the secondary would be the weight loss and the night sweats and stuff like that. Very good job. Them spider legs can cause a lot of damage as they grow. Y'all were doing so good, and we split y'all in half. So malignancies, remember, the avocado seed doesn't do anything but just grow in its little encapsulated self. So that's really all it does. It doesn't do any other problems. Malignancies, however, they create a life of their own. They start secreting various chemicals. One of the biggest ones is a lung tumor that secretes ADH. Like it makes its own ADH. So then you end up with people who don't urinate because they're secreting fake antidiuretic hormone. So you actually learn about that in 211 when you guys go over SIADH. So we'll talk about it a little bit with neuro too because we're dealing with the brain. But so a lung tumor secretes a brain chemical, very random and weird. And then other tumors can secrete hormones, estrogen, testosterone, stuff like that too. Very good. Pop the avocado seed out, then come back. Typically. Whereas malignancies we know are very high risk of reoccurrence. Even when we do all the things, a lot of times they still reoccur. If you have a benign tumor that's growing on your airway, can it kill you? A little bit. The brain tumor that I told you about that my doc would tell me he would just pop it out like an avocado seed, we're going to learn that your skull does not expand. So if you have something growing inside of your skull, that will kill you. It must come out because there's nowhere for it to go. So typically the only time a benign tumor is going to cause death is when it's pushing up on something that makes it stop working, like your airway. All right, done with those. Now there's just questions.
Oh, wow.
Okay. Well, this was a straight up guess, wasn't it?
Yeah.
I figured so. All right, let's go through the phases of cancer development. So the first phase is going to be initiation. That's why I didn't say what's the first phase, because I feel like that one y'all probably could educated guess that one, so I had to go second. The first phase is initiation. This is when your cells start to mutate. So who should be killing these cells as they start to mutate? Which cell that we learned about last week? The natural killer cells. And who should be flagging these cells to be destroyed? Helper T's. All right, we got one of them confidently. The other one not quite as confidently. So during that initiation phase, your helper T cells should be flagging these mutated cells to be destroyed. And your natural killer T cells should be going around trying to just kill them as they see them. So, but sometimes they go undetected, or they're growing or mutating too fast of a rate to be caught. So initiation is the first phase where they're getting mutated. It's also, we may be exposed to a carcinogen, or have repeated exposure to a carcinogen, such as tobacco smoke, asbestos, various things, lead, mercury. So that's the first phase, which is initiation. Promotion, this is really where we start to have those precancerous lesions, so we have enough mutation to where it's actually grown into somewhat of a mass. So further changes to the cells happen. So this is really the best time. This is why we do colonoscopies on a regular basis, so because we can catch a lot of these precancerous lesions in the colon and get those removed prior to them turning into something. This is why we recommend skin checks often, so that you can get precancerous skin lesions cut out. So promotion is that second stage where we see precancerous lesions. That's where we really want to focus on all of our screenings to try and get those taken out. And then the third phase is progression. Proliferation, I just thought sounded like a good word, so I threw it in there. It really has nothing to do with anything. There's only 3. But it sounded good, didn't it? It sounded really good. Progression, that's the third phase. This is really where the tumor starts to create its own blood supply and starts to form its own nutrition system to feed itself. This is where we start to get those secondary characteristics. This is why the patients start to lose weight, because the tumor is now stealing all the nutrients from the person to feed itself. So it's truly like a whole nother entity within our body, just stealing all of our nutrients and our blood supply. Very good. So all of these are obviously carcinogens. Tobacco smoke is the most lethal, because you don't even have to be the person smoking in order to be affected by it. If you're just around people smoking, you can be affected by it. Tobacco smoke not only causes lung cancer, it also is the #1 cause of another type of cancer. Can you guess? It's completely random, and you never would have thought about it before. That's a very good random guess. Bladder. Bladder cancer, the #1 cause of bladder cancer. Very random. So I told you, random and weird. Isn't it?
#1 cause of lung and bladder.
Lung and bladder.
From what?
Tobacco smoke. My uncle that smokes like a chimney didn't get lung cancer, but he got bladder cancer. Just random.
Not mouth cancer, not
I know. So mouth and esophageal cancer, the #1 is tobacco, just
Chewing
not the
tobacco.
smoke. Yeah, chewing tobacco is the #1 cause of the jaw, mouth, head and neck cancers. Those are fun surgeries to take care of, the radical necks. I want it to be. A lot of fruits decrease your cancer risk. Antioxidants, get rid of all of the fruits. Helps to rid your body of free radicals. So fruits are very good for you. I have to hawk my blueberries. Ooh, blueberries. I love blueberries.
I love frozen.
There you
Dark
go.
chocolate.
Antioxidants. I don't care as long as you get them in your body. I love covering mine with the Nutella. Red meats actually links to colon cancer, so red wine they say helps thin your blood. I think that was just something rich people said one day so they could justify it. Coffee doesn't really help much in that. I know, it helps me stay alive, which is, I've not had coffee today, so it's a struggle on many levels,
I
but.
don't know how you're, what is your poison
Gatorade. A lot of Gatorade. That's probably why I look so bad. I haven't had coffee for 2 days. No coffee for 2 days. I'm gonna chalk that up to wellness. Very good job. Yep, there's a lot of viruses. What's the one that springs to your mind? HPV, yep, Epstein-Barr, so several viruses can contribute to cancer development. Good job. I figured this was a total guess too. So the whole point of this question is not to give you the actual percentage. It's just to point out that as we get older, your cancer risk increases. So sorry, our cancer risk goes up as we get older. A lot of that's because our immune system just doesn't function the way that it does when we're in our 20s. So yay for the 20s. Yeah, that's been a
Blow it up
long
now,
time.
girls.
Woohoo. So cancer deaths, I think the #1 diagnosis might be colon, but actual deaths goes with lung. They're all bad.
Now I love younger age of colon cancer.
Yeah, I think the #1 actual diagnosis is colon cancer, but deaths is gonna be
Do you
lung.
think it'll go down in the next 50 years?
I don't know, especially with colon cancer spiking in young people, it's crazy. And I don't know why. There's a lot of theories, a lot of theories. also see this with, like in third world countries where you have a lot of starving patients, and then you also see it with HIV in the end stages as well, or AIDS in the end stages, is cachexia. So that's how you say that fun word, is cachexia. So this is, our cancer patients actually have about 3 different reasons why they become cachectic. So number 1 is what we talked about, the cancer actually creates its own way of stealing all of their nutrients, which also causes a lot of anorexia for the patients in general. And then if they're on treatment as well, a lot of our chemos cause a lot of anorexia also. But just in general, if you have a cancer patient who has a tumor that's actively growing, that means you're having a lot of cell division because the cells are growing. So that does what to your metabolism? Skyrockets. So your metabolism is going through the roof because you're having a lot of cell division and multiplication. But now you've got this tumor that's stealing all of your nutrients. So these patients lose weight, and they lose weight quickly, and you guys have seen that, right? Whether it's been in clinical or somebody in your own family. Unfortunately, a lot of us have dealt with this within our family.
So real quick, the 3 reasons for cachexia was cancer, steal nutrient, chemo, and cell division to increase metabolism.
And just one of the other secondary side effects, or secondary cancer effects, is also anorexia. So we said it was weight loss, but we didn't throw anorexia in there too. Good job. I didn't think that. We'll do that one this time. Alright, so let me get to my PowerPoint on cancer. We'll finish up our last little. Nope, not it, wrong one. I know I'm skipping around, but it's what I wanted to deal with first, so. Alright, so we've kinda already talked about a lot of these things with the Kahoot. So just kinda in general. Let's talk about, so if you think about primary cancer prevention, what do you think about? Primary cancer prevention. Primary cancer prevention. Yeah, so good, healthy, anti-cancer lifestyle choices. So eating good foods, not smoking, limiting your exposure to carcinogens, getting vaccinations against some of the viruses that are known to cause cancer, like the HPV. So those are primary cancer prevention. So just good, healthy lifestyle choices and limiting your exposure to carcinogens. So that's gonna be our primary prevention. Now our secondary prevention is, what you guys said a minute ago, screenings. So secondary cancer prevention is gonna be your screenings. So you do not have to know all the screenings and all the ages that it has to be done, because honestly that changes up pretty frequently. Like they used to have a lot of rules for cancer screenings, and now they've kind of backed off some of them. Like they used to do pap smear for women every single year. Now they do it every 3 years. So just those things change. Just know that we have screenings for cervical cancer. We have screenings for colon cancer, for breast cancer, prostate cancer. So we have a lot of different screenings. The ages have changed over the years, so I'm not really worried that you guys know the ages that it has to be done. So just as we get older, the cancer screenings do increase. We have to do them more often, and we have to add ones that maybe we didn't do before. So because we know as we get older, our cancer risk increases. Tertiary cancer prevention, that's mainly if you've already been diagnosed and been treated, and now we're watching out for it either to return or for you to have a secondary cancer. So primary, we're gonna limit exposure. Secondary, we're gonna do screenings. And tertiary, we want to prevent reoccurrence. All right, we talked about the primary symptom, or we went over all the benign versus malignancies on tumors, how to recognize the differences. What I gave you guys is the classic examples. There are always exceptions to the rules, but those are overall the same, or the expected characteristics. Primary symptoms are gonna affect whatever organ is being affected. Secondary, we talked about those. Alright, let's talk about treatment options. So we have, I've broken them down into 3 different categories. So surgery, what does debulking sound like? So we're gonna take the majority of it out, so as much out as we can. This is typically with those little spidery legs tumors, it's really hard to get out all the spidery legs, but we're gonna take out the majority of it or the bulk of it, and then we're gonna have to combo it with either chemo, radiation, or both. So debulking is just, we're trying to take out a large portion of it so that we have better results. That is never done as just surgery. Like, it's always gonna be combined with either chemo, radiation, or both. Because obviously we're leaving some tumor in there. Curative, what does this sound like? You take it all out and we're cured. There are several tumors that you can take it out and not have to do any more. One of my friends had breast cancer, and it was at a stage in a location where they took the tumor out. She didn't have to have chemo or radiation. So prostate, sometimes we're able to take the prostate out, not have to have chemo or radiation. So it just depends on the stage of the tumor, where's the tumor, are we able to just do surgery and not have to do anything else. Hormone removal. So this is, we see this the most with breast cancers because breast cancers love estrogen. So patients with breast cancer tend to have their ovaries removed as well so that they stop secreting all of the hormones that feed their cancers. So my oldest friend that I've had since, we all have, hopefully, I hope you do, have a friend that you've been friends with since elementary school. She was diagnosed with breast cancer when she was 34, and it was a stage 4 when she found it. And she had to do the double mastectomy, but also to do hysterectomy, ovarian, fallopian tubes. Basically everything had to be taken out because of how strong her tumor was fed from hormones. So everything was removed, even though it was just breast cancer. Unfortunately, her cancer did recur, so it came back in her liver and in her lymph nodes, and so it was still actually diagnosed as a stage 4 breast cancer, even though it was in her liver and her lymph nodes now. Very happy to say she's doing well. She's still doing chemo and still doing good. I'll talk about her a bunch, obviously, because she's had to deal with all 3 of these things. She's done surgery, chemo, and radiation.
Did you say it was seen mostly in breast cancer?
For the hormone removal, is mostly breast cancer, because those cancers are just fueled by estrogen. So we go ahead and take out ovaries, do a hysterectomy, everything, to try and get rid of all the hormones, to stop feeding it. Palliative, what does this sound like? Yeah, so a lot of these tumors are extremely painful, so they may not be curative. We may not be able to do anything treatment-wise to save this person's life, but we don't want the end of their life to be in a lot of pain. So we'll go in and try and take out whatever is causing the person pain, and hopefully they have a much better quality of life for however short or long it may be. Liver cancers particularly, and bone cancers can be extremely painful. So they may go out and go in and take off whatever is pushing up against other organs to try and get them some relief.
Did you say liver and bone?
Yeah, I mean, those are kind of neither here nor there. It's just ones that I've seen medicine and opioids, and it just doesn't touch their pain. It's such a deep inside their body pain, so we can do a palliative surgery to hopefully remove that pressure. Reconstruction is what it sounds like. So reconstruction surgery to try and restore any type of body image that we may have had before. So obviously a lot of breast cancer, this would be breast reconstruction. A lot of times we have to do surgeries that may be on one side of the body and not the other, so they may want to have surgery on the other side of the body to try and match. So reconstruction, that would be after healing's already done.
Will insurance cover that?
A lot of times. Yeah, so we're just trying to match up wherever we had surgery in the first place. So concerns to consider, obviously post-op recovery. You guys have gone through your post-op care module in 113, so you guys know about post-op recovery. Body image concerns, because obviously we're going to be taking out a part of the body. So with our women, a lot of times, like my friend had to deal with a lot of body image concerns because of losing both breasts and then also losing uterus and hormones and everything. So from a mental health perspective, she struggled a lot with, you know, just a lot of different things, not only from the body image concern, but also from a mental health concern as well. All right, chemotherapy. So we can do chemo a lot of routes. We kind of talked about this last week, so I don't have to go into a lot of this. So we can do IV chemo. If we do IV chemo, it is a vesicant, so we have to have, typically we go in and do a portacat. So did y'all learn about portacats in what, 113? No? Oh well, here it is, portacat. So implanted under the skin, so you see the picture over there. Have y'all seen a patient with a portacat before sticking out of their chest? So a little mixed bag, some of you yes, some of you no. So it stays under the skin, so when they go home, they don't have to do anything special for like showering or bathing or anything, because everything is under the skin. When they come in, we'll access it with a very specialized needle. And it's just like starting an IV. You just kind of stab the needle into the portacat, then it can stay for 7 days. So typically we, just pop it in to do the chemotherapy and then take it out. You just got to make sure when you take it out, you flushed it very, very well, because that tubing is up under the skin going into the blood vessel. So if it gets occluded, there's not really much I can do about it. So before you take that needle out, you have to make sure it's flushed very, very well so that it doesn't get occluded for them to use it the next time. You can draw blood from this. It's a central line. So it's going to the exact same place the central line is. If you notice, you can kind of see how this is tunneled up under the skin right here on this lady. It's actually going into her internal jugular. So you can draw blood, you can give meds. So, but this is what we typically do for our cancer patients, because they are having to come in and get frequent IV injections of a vesicant. Yes.
When would you leave the needle in for 7 days?
Like if they're in the hospital for any reason, like instead of starting an IV, just access their portacat. That way I don't have to stick their arm and they got an IV.
How long does the portacat stay?
It can stay forever as long as it doesn't get infected or occluded. Like some people just don't take it out. They just leave it. Like if they've got other issues, like if they have to go in the hospital for other reasons like CHF or diabetes, they may just keep it. Say, no, this is easier access than starting an IV on me. But a lot of people get it taken out once they're finished with their chemotherapy. So chemo, it is a vesicant, so that's why we do the portacat. A lot of concerns to consider. So you guys hit pretty much a good bit of these. There's 2 on here that I want to talk about that are a little bit more related to do with the cancer as opposed to just chemotherapy. Because you guys hit on your poster the bone marrow suppression, anorexia, alopecia. You talked about family planning concerns. So if you wanted to have children later in life, we need to talk about sperm banking and egg banking, because you do not want to get pregnant with an egg or a sperm that's been exposed to chemo for several years. I can't remember if it's 2 or 5 years off the top of my head. And if you're right at childbearing age, you gotta get through all this chemo and then wait the extra amount of time to start a family. That may not be what is in the cards for people. So egg banking and sperm banking are something to talk about before we start treatment. And then future cancers. So future cancers, because chemotherapy is actually destroying cells and it's very much suppressing your immune system, we actually are put at risk to develop leukemia later in life. So I think that was on the poster too. Was that on the poster? Like leukemia is later? I can't remember. I thought it was. So leukemia is a blood cancer. So because of how much chemotherapy damages the bone marrow, we are at a high risk of developing leukemia later in life if we've had chemotherapy. So yay, we treat your cancer and then we cause a cancer. But it's a risk that we understand we're taking at the moment. All right, TLS. Let me go back up here to this one because that's not one that we talked about. This stands for tumor lysis syndrome. What does that sound like? Lysis, what does that word mean? Destroy, kill, rupture, blow up. Yep. That's our point, right? Our chemotherapy, we're trying to blow up these cancer cells to kill them. When a cell ruptures, what gets put into your bloodstream? Everything that's on the inside, right? So what's on the inside of the cell that's going to get dumped out to your bloodstream? None of that sounded confident.
The cancer.
No. Because the cancer is the cell. What's on the inside of a cell? How about if I say the word electrolyte?
Potassium.
There we go, potassium. So if you break open a cell, it's got potassium on the inside, which is now in your bloodstream. All right, so TLS, tumor lysis syndrome. It is a combo of 4 electrolyte, electrolyte imbalances. 3 electrolytes and 1 little extra thing. So TLS is going to consist of hyperkalemia, because that potassium is going to get dumped out to the cell. So hyperkalemia, hyperphosphatemia, because phosphorus is going to get released. If you've got a high phosphorus, what are you going to have a low? Low calcium, so hypocalcemia. And this is the one little random one. You have high uric acid, so uric acid also gets released. So that's why I said it's really 3 electrolytes and 1 kind of little extra thing. If I say high uric acid, what do y'all kind of think of? Not what I was thinking.
That's what I was thinking.
Like gout?
Yeah.
Gout and kidney stones?
Sure.
So those are the kind of the 2 big things I think of. So it's an electrolyte imbalance. High phos, high potassium, low calcium, and high uric acid. So how do we treat that? Do what? I can't hear. You're probably
That's how you
saying-
normally treat
Yeah.
fluid electrolytes.
Yeah, how we know how to treat fluid electrolyte issues. We already know that. So a lot of it is hydration, trying to flush all of it out. But then we might also add some furosemide. So that sounds kind of weird, don't it? You give a lot of fluids, and then you give Lasix. So we're talking about people with hopefully healthy kidneys. So we're trying to flush everything out, but then we'll add some Lasix to try and help push that potassium out a little bit too. And try and get that phosphorus out. A lot of times that kind of fixes itself. So we treat the electrolyte imbalance just how we expect to treat an electrolyte imbalance. So it's just something that we're going to watch out for. So patients on chemotherapy, we're going to be doing electrolyte panels to watch out for TLS occurring. have two different kinds of radiation. We've got internal and external. So internal is called brachytherapy. They can do internal radiation two different ways. They can either, under some local anesthesia, they can insert basically like a little tube that emits radiation. They'll irradiate the area and then take the tube out. So then the person is not considered radioactive when they leave. So they don't have to do all the radiation therapies when they go home, or concerns when they go home. Or they can implant seeds, and the seeds stay until they get removed. So prostate cancer is probably the most common time we see this. So they can implant radiation seeds in the prostate, and then they just kind of come out through their urine. So if anything is left in the person with radiation, then they're going to do the radiation concerns for about 2 weeks. So if I say radiation concerns, what you think of? Yeah, isolation. Don't need to be around kids, pregnant women. They really need to sleep in their own area, use their own toilets. They really need to be kind of separated out for about 2 weeks. We don't do that quite as often as we used to. But if anybody goes home and they've got radiation seeds implanted in their body and it's staying, then we're going to do those things. Just kind of stay away from people during that active radiation time. And then definitely stay away from kids and pregnant ladies. External, this is where they're going to come in and just have radiation externally. So they'll have skin markers on them. So the big thing for us is if you see somebody with skin markers, do not wash them off. They're pretty resilient, but do not wash off skin markers so that they know where to aim their radiation beams. So concerns to consider, radiation precautions, and then skin damage. So my friend that had breast cancer, she had huge wounds from radiation. She was having to do so much wound care on her breast area after she had had a mastectomy because of all the radiation. So skin care, wound care, just if it progresses to actual wounds like hers, she had to be taught how to do wound care at home, just like we would in the hospital. So daily dressing changes and making sure she keeps everything clean. I have another friend that had to have radiation. He had a tumor that was right here on his neck. So he had to have radiation to this side of his neck. So what kind of concerns would you have somebody having radiation right here? All right, so he was having some jaw pain. What else? No. Probably thyroid. It's a little bit lower.
Any pain in your artery?
Like all your mucosa and swallowing. So all of that mucosa, so that's where I was going with the second one, mucosa damage. So swallowing became very hard for him. Like he could not eat a lot of solid foods. He had to have very thin foods, a lot of soups. Could not taste anything. So any type of radiation to the head, neck, and upper chest area, we worry about the esophagus, the mouth, all of that mucosa, which makes nutrition very hard to accomplish. If you have radiation to your chest right here, we're worried again about esophagus, top of your stomach with hernias, things like that. So we're worried about all that mucosal damage. So anywhere where we're pointing radiation, you're not just irradiating where the tumor is, you're also irradiating all that healthy tissue as well. So we can see damage with those healthy tissues. It can cause long-term damage, and it also can cause future cancers as well, especially depending on where you are aiming the radiation at. It can cause future cancers. Alright, so let me see if we've got that's mostly it with cancer. Because y'all talked about a lot of that with chemo and. Alright, what questions do we have about cancer? Which is all of the cellular regulation content. That was the only exemplar in that content. Any questions? Yes?
One more time, I got external was the skin markers, you don't wash them off, but internal was the seeds, and you said like cool and they'll like leave it, but what did you say before the point?
They could just do radiate under like local and just insert the radiation beam and directly put radiation to a certain area, and then they take it right out, so they don't have to deal with any of the isolation stuff when they go home.
So with that, we just need to know.
There's really not much to know about it. It's something they can do. But it doesn't have any like kind of teaching and education that we would have to do for them to go home. Alright, well, let's take a break and then we'll finish up the rest of it. Are we all back and ready to go? No, but yes. Yes, but no. Alright, so now we're gonna cover HIV and AIDS. So I have 3 things and we'll go back and forth between. So HIV.gov, this is your resource. Like, this website is so good and it's up to date, whereas, you know, textbooks when they're printed, they're already out of date. This website literally updates constantly. Like, I will go to teach something from it, I'll check it the day before, and it will be updated and changed than when I go to teach the next day. So it's always being updated, it's always being changed and kept up to date. So it's a really great website. I feel like it's really a website that's written at a good level for healthcare professionals, because it's got enough of our kind of high level stuff that we need to take care of patients, but then it's also written at a really good level for the lay people to understand as well. So this is a great website. You will learn so much from this website, which we will see in a minute. So I'm gonna kind of walk you through it just a little bit as we go through, and then I've got a video and just talk about some things. So when you click on this, it'll drop down, and you've got some great things. This is always one of my things that I find so interesting. HIV was discovered in 1981, so that's a great thing to share a birth year with. Me and HIV came into this world in 1981. So this will show you all of the news headlines from each year, all the way up until now, until 2025. 2024, I take it back. No 2025 headlines. But let's see how HIV started. HIV started, so I'm a little older than HIV since my birthday is in April. So June 5th is when we discovered something really weird happening. So 5 young men, so I think they were in their 20s. So 5 healthy young men came down with the same immunocompromised disease in New York. They all had pneumocystis carinii pneumonia. Now that name is now updated and changed. That's not the current terminology for that name, for that disease anymore. So they all came down with this same disease, and the only time you see this disease is this type of pneumonia in extremely immunocompromised people, like homeless people that have a lot of comorbid issues, cancer patients. Like, you don't see this in healthy people. And they all died. The only thing that they had in common is that they were homosexual. That was it. So this is where a lot of the fear came from back in the 80s and 90s that this was, quote, the gay disease, is because this is the first time we saw it, and then it just like skyrocketed through that community because we didn't know what was going on, how to prevent it, what it was even about, and so it just perpetuated that stereotype. And we know that killed a lot of non-homosexual folks because they thought they were protected because of where they thought this disease came from. So it took us a really long time to figure out what this was and how it was killing people. So in all the spare time that you have, because I know you have so much, you can go through and look at all the different headlines. They've got, like, on here, Ryan White, if y'all seen on Netflix, Ryan White's got a whole documentary on him. So Ryan White died at 18. As you click through this, you'll see a lot about Ryan White, and you'll see a lot about the Ray brothers. So a lot of our legislation related to HIV is named after Ryan White and the Ray brothers because they were all young hemophiliacs that got diagnosed with HIV from a blood transfusion. So they were severely bullied. I think it was the Ray brothers, I can't remember which one it was, like their house was burned to the ground. The town was trying to run them out of the town because there was, again, just so much fear and unknown about this disease. Severely bullied, their parents were all fired from their jobs. I mean, it's a really sad story. So a lot of our legislation is written in their honor because of what all they went through. And they were very, very strong advocates to try and understand what this was, how it's developed, and then how can we prevent it. So you can read a lot about what their families did after they died throughout this timeline as well. It's also got when various people got diagnosed. Is it 87? I can't remember. It's got on here where like Magic Johnson got diagnosed. So it's got, there's where condoms got declared as the prevention. So there's all kind of different things that tells you all the different kind of like famous people, like when they got diagnosed, when they passed away from HIV. So it's just an interesting little thing to click through. But that's the timeline of how HIV came, everything that we learned and when it happened. So it's also got a lot of things about your statistics, which I've got some graphs that I actually stole off this website. The graphs are no longer available, so I'm glad I got them before they went away. Because the statistics are still accurate, they just took away the graphs. I mean, who takes away a graph? It's a pretty graph. We're going to go through PrEP and PEP, a lot of the prevention. We're going to go through testing. So we're going to come back to this a lot. So these are the statistics that were on the websites that they took down. I have verified these statistics are still accurate. It really hasn't changed from 2021. I don't know why they didn't, I guess because they didn't set the new graph up. Look at who has the highest number of new diagnoses as far as region goes. 'Tis us, y'all. So the South has 50% of new diagnosis. So you can't read the fine print because it's super tiny, but this is new diagnosis. This is not people living with. This is new diagnosis of HIV. And this is pretty much still the same in 2024, the last time they pulled statistics. So the South, we still have a very high rate of new HIV diagnosis. This also is pretty much the same since 2021. Our Black African American population is still our highest at 40% throughout the whole country. I don't have a slide, but let me pull it up on here. Because I think they did have a graph. It's still, they use the term MSM, which is males having sex with males. That is their term for how they count the transmission. So males having sex with males accounts for 67% of new diagnosis. So it still is our highest group of people with new diagnosis. 22% is with heterosexual contact. Inject drugs, 7%, so extremely minimal on drug use. So largest number of group is still our young people, 25 to 34. is still our highest group. But really, it's it really knows no age, because it says that the highest group it's still that, yeah, it's just, it hits anybody. So what is HIV? I have a little video to explain how HIV, so I thought this was a great little video. It's how, when you're exposed to HIV, how it actually changes the structure of your cells to proliferate. There's that word, I can use it.
When a virus winds up inside the body, it's usually met with a furious onslaught from the immune system. White blood cells immediately respond by releasing antiviral proteins, attacking infected cells and recruiting back up. Usually, this is enough. But there's one virus that pushes the immune system beyond its limits: HIV. HIV infects one of the immune cells that is central to the body's response to pathogens, the helper T cell. First, the virus attaches and enters. Once inside, the virus moves towards the nucleus along with its enzymes and genetic material. One of these enzymes, reverse transcriptase, converts the viral RNA into a length of DNA, which inserts into the cell's genome, forcing the cell to spew out HIV proteins and genetic material to make new copies of the virus. These new viruses escape the cell to infect others. HIV levels rise rapidly in the body. But the immune system doesn't go down without a fight. Inside infected cells, antiviral proteins called restriction factors work to shut down virus production, whilst others stop the virus from escaping the cell. Outside, white blood cells called B cells produce neutralizing antibodies, which bind to surface spikes on HIV particles and stop them entering healthy helper T cells. The greatest assault comes from killer T cells and natural killer cells, which seek and destroy infected cells directly. They release a protein called perforin, which punctures the infected cells, allowing enzymes to be injected, triggering auto-destruction. For a while, the defense holds and virus levels drop. But HIV begins its counterattack. It disables the cell's antiviral proteins, allowing new virus particles to leave the cell. It also constantly mutates inside the cell to evade detection. The immune system can't fight what it can't see. Eventually, the immune system wears itself out. Killer T cells, activated for too long, become exhausted and no longer respond to infection. Also, the body loses the ability to make new helper T cells to replace those killed in the fight, and as a result, their numbers plummet. Ultimately, the body becomes immunodeficient, and this condition is known as AIDS. Without treatment, exposure to otherwise harmless microbes can be fatal. We still have no way of eliminating HIV from the body completely. There is no cure, and hidden reservoirs of HIV will rebound if treatment stops. But treatment with antiretroviral drugs can swing the balance, allowing the immune system to recover from battle and live to fight another day.
I just love that little video. It's just cute. If you want to watch it again, it is on your HIV case study. There's also this video up here. Control. You're supposed to go to it. Oh well, we will look at it later because it don't.
So this is HIV. It's a typical retrovirus, meaning that it has an outer envelope.
So this is another video that's really good, that is very colorful and explains how HIV works as well. I highly recommend kind of watching it on mute, because unless you're really good at A&P and you remember all of those words like reverse transcriptase and mitochondria and all that kind of stuff, it really goes, but it's really pretty, and I think just pictures alone kind of helps you understand it. But those are the two videos that I have on HIV, on how it infects the body. So this is kind of that same picture. It's a HIV cell coming into the body, into the helper T cell and replicating itself. So with all that being said, stages of HIV. So we've talked about the number one way HIV is transmitted is it kind of broke it down into different groups of people, whether it's males having sex with males or heterosexual transmission. If you put all that together, the number one way HIV is transmitted is through sex. So the other way that they have accounted for is injecting drugs. That was only 7%. So sexual contact is by far and large the way we get HIV/AIDS. So there are 3 stages to HIV and AIDS. So the first is your acute infection. So those are the symptoms of the acute infection. Kind of looks like just the flu, don't it? There's really nothing there. This occurs about 2 weeks after a sexual encounter. So a lot of times people just think they're sick. Unless they're really thinking about what they did maybe 2 weeks ago, whether or if this is a habitual lifestyle choice. So acute infection is the first stage, and there's really no big symptoms. You're just kind of sick, just a viral sickness. Stage 2 is chronic latency. So chronic latency, this is where all of those white blood cells have mounted that defense, and they're kind of keeping the infection at bay. So left untreated, this stage can actually last up to 10 years. That's untreated. Because our body is just really good at trying to protect itself. With treatment, this is the stage we want to live in. So all treatment is doing is keeping us in this stage. Stage 3 is when we actually, our diagnosis is converted from HIV to AIDS. So the way we get our diagnosis converted to AIDS is it's an and/or situation. So your CD4 count, which a CD4 cell is a what kind of cell? That's your helper T cell. So your CD4 cell count should be like 1,000 is the normal. So if your CD4 count drops below 200, your diagnosis is now converted to AIDS. So the normal should be over 1,000. So if it goes down to less than 200, you are diagnosed with AIDS. And or you are diagnosed with an AIDS defining condition. So it could be and or. So one or both. Either one of those things get your diagnosis converted from HIV to AIDS.
What would be an AIDS defining condition?
All right, so if you look in your book, there's a table this long of AIDS defining conditions. I really want you to know two. So, I don't feel like going through this whole case study today, so we just gonna kind of skip a lot of the details. So thought I had it put on here. There we go. We're going straight to his update. So, pneumocystis, I don't know how to say that word. Hograsy pneumonia and Kaposi sarcoma. So we're going to go over those two defining characteristics because these are the two most common. So that's why I want you to know those two. They're the two most common AIDS defining conditions. But there's a whole lot more of AIDS defining conditions. Most of the AIDS defining conditions are going to be opportunistic diseases that we rarely ever see. So it's not going to be something like a common issue that you see in the hospital all the time. It's like these weird things like cat scratch fever or something. You know, like all those diseases that are so random you've never heard of. That's kind of what if you wanna think of an AIDS defining condition. But these are the most common. The pneumocystis jirovecii pneumonia, this is the new terminology. Remember when we saw that pneumocystis carinii pneumonia on the HIV website? It has been renamed because they actually discovered it's a fungus instead of a bacteria. So they had to change the name because it's not a bacteria, it's a fungal pneumonia. You guys come in contact with this fungal pneumonia every single day. Like it's on the tables, it's on the floor. It's an extremely common little fungi, but this is one of the things that your body laughs at. Like, really? You want to try and bring that here? Like, I destroy you instantly. So this is why, like, you should never get infected with this. Your body destroys it so easily. So when they had those 5 young men come down with this type of pneumonia, they were real confused. Like, what the heck? Why'd your immune system not take care of this? Kaposi sarcoma is a cancer. It's typically seen in the oral cavity, so in the mucosa. It can be on the skin as well. They look like little purple bruises. So typically in the oral cavity, but can be on the skin. Just looks like a bruise, but it's actually a cancer. And again, this cancer, your body usually destroys these mutated cells so quickly that for them to come down with this type of cancer is like, why is your immune system not protecting you from this? Like, this is not a cancer that people typically see. So we usually only see this type of cancer in severely immunocompromised people. So those are the 2 AIDS-defining conditions that I want you to know. But if you just feel like looking them up in your book, you can read the whole table of all the weird diseases and go down a rabbit trail, if you so should choose. Up to you. So, alright, so let's look at more of the website. So we talked about how it's transmitted. Let me see if they've got any. This is where you can learn a whole lot of things from this website, should you choose. Like, you can learn all the different sexual things that you can get HIV from, and all the different sexual things that are safe, and it gets real detailed. So I'm not scrolling any further. Feel free. Who is at risk? All peoples. All peoples are at risk for HIV. However, we do have people that are higher at risk than others, which we talked about. Who do you think in the world has the most HIV diagnosis?
They can talk about gender or?
Country. Which country has the highest HIV diagnosis in the world? It's not us. So it's sub-Sahara Africa. So Africa has the highest number of HIV diagnoses. Sub-Sahara Africa. That's just a little FYI. Okay. Let's see. Let's go HIV testing. Testing overview. We have several ways that you can be tested. So the first type of test is a screening test. If you have a screening test, which screening test you can do at the doctor's office, you can do it in the health department, you can go on this website and say, hey, I want to do an HIV test, and they'll send you one in the mail, and you can send it back. So you can do it completely anonymously. A screening is just that, a screening. Is it a diagnosis? No, it's a screening. So it's usually the little like lollipop thing you just stick in your cheek and rub around, and then you send it off to the lab. So a screening is just a screening. They're either going to come back and tell you you're clear, or you need to go have further testing. So what other types of testing do we need to do? Let's see if it goes with this. If your result is positive, you need to go in for further testing. Oh, they have a new video. I haven't seen that. I'll have to watch it later. These are 3 types of HIV tests that you can have done. I don't care that you know those. I'm changing my mind. This is new too, like I'm discovering as we are going. So, essentially when you have one of these tests, you're gonna get the diagnosis. So, you're gonna get a diagnosis test. You're also going to get once you test positive with one of these tests, they're also going to do a viral load test. So viral load is exactly what it sounds like. You have to get your diagnosis to say yes you have it, which is one of these options of a test. And then you need to get a viral load test done to see how much virus is actually in your body. Viral load testing is going to be done throughout the lifespan, just on a routine basis. So once you've been diagnosed with HIV, you will have viral load testing done throughout the rest of your life. This is to let us know if your treatment's working, if your treatment's not working, if we need to change anything up. So these tests are done just the one time to confirm diagnosis, but then viral load testing is done throughout the rest of your life.
The viral load just a CBC.
No, it's an actual, it detects how many HIV viruses are still floating around in your body.
So the first one's like a baseline and then you start treatment.
Yes. Yeah, so these tests, one time, viral load, rest of your life. Alright, so the viral load test, that's gonna let us know, again, if your treatment's working, if it's not working. Our goal for viral load is it to be 0, which is you are undetectable, essentially. That's the goal of our treatment. So we learned about our art therapy treatment last week. So starting staying HIV care. HIV treatment overview. So this HIV treatment overview, this has got a lot of great information, like what our group did with the art therapy. This is where I told them to go to get all the information for their poster. This is a learning about art therapy, and they put a lot of this on the poster for you guys, but this is where they pulled it from. Once you start art therapy, the goal is to get your viral load down to 0. So if you can get your viral load down to 0, you're labeled as undetectable. Did I say you are cured? No, I did not. You are not cured. You are never cured. We do not have a cure at this current moment in time. It is hopefully one day going to be the case, but not right now. So our goal is for you to get to undetectable. If your viral load is a 0, you cannot transmit it to another person. You have a normal life expectancy. So we said in those stages, the one we said stage 1 was the acute infection, the chronic latency stage, untreated was 10 years. Our goal with art therapy is to keep you in that chronic latency stage until any other person, just normal lifespan. Even if your diagnosis is converted to AIDS, let's say you have a flare-up really bad of virus, something happened where you got really triggered, maybe you had to come off your medication for a little bit, I don't know, pick a scenario, and you were actually converted to an AIDS diagnosis. Now your diagnosis is going to stay the same. Like we never back diagnosis. We never say, once you're diagnosed with AIDS, you never go back to HIV. Like you are always an AIDS patient from that point forward. But it's really just about labels. If you can get started back on your art therapy, you still can go back down to undetectable. So really I want you to think of HIV and AIDS as far as like the difference with those diagnoses. Like if you flare up one time and that CD4 count tanks, or if you get one of those, that pneumonia or that cancer, we've just converted your diagnosis. But we can get you back to undetectable and go back to normal life with treatment.
Can your CD4 go back up?
Yes, with treatment.
Okay.
The art therapy can get your CD4 count back up.
But your diagnosis won't change?
Right.
Okay.
We just don't back diagnose.
Yeah.
It's just like you don't backdate a wound. Like if you have a stage 4 wound and it heals up,
Okay.
it's still a stage 4 wound. It's just now healed. Same thing with my friend with stage 4 breast cancer. Still stage 4 breast cancer when it came back. We don't backstage. I didn't tell you guys untreated with the AIDS phase. Untreated with the AIDS phase is less than a year till death. So it's untreated. Treated, normal lifespan. So we got to get you on treatment, on therapy. This is the only way they survive, is this treatment. Yes.
So just to clarify, the chronic latency is up to 10 years untreated,
Untreated.
and AIDS is up to 1 year.
Untreated.
Okay.
But treatment, full lifespan. So I think that answers why is HIV treatment important. Would you like to live or not? It's very important. When should you start? As soon as possible. You get that confirmation test that you do have the diagnosis, you should be finding out where your treatment can start that day. Like, treatment should start as soon as possible. It is safe for pregnancy. One thing that we didn't talk about was transmission to babies. So what do you think our statistics are in the U.S. for babies born to HIV positive mothers and the babies staying HIV positive throughout their life? What do you think our rate is of that actually happening? It's like 0.1%.
Wait,
So if you have an HIV mama and she has a baby, the chances of babies staying HIV positive is like 0.1, 0.2, something like that.
Why though? Because of treatment?
Because of treatment. Like, if we get mama on HIV treatment, we have to put baby on HIV treatment when they're born, because it's still got some mama's blood floating around in them. We don't breastfeed those babies from mama. But if we do, once all of mama's blood gets out and baby just has their own blood, HIV negative. So we have really,
but that's
really
only
good
if
rates.
mom's on treatment. Like, if she's untreated HIV, she can live up 10 years, has a baby in those 10 years, I'm assuming that percentage goes up.
Say it again, my brain don't want to work.
If mom stays untreated in those 10 years, and she has a baby in those 10 years, I'm assuming that percentage goes up.
Yeah, this is
Of baby having
with
HIV.
treatment, yeah. We rarely have babies, like, we typically know. Typically know when mama's on HIV. Is that I need to find out, is that a mandatory or not a mandatory, but is that one of the normal tests they do for mamas now? Do they do those? HIV testing? Do they do that?
When
Do
they're
they do that with
pregnant,
mamas?
they usually go ahead and do it, as soon as they find out they're pregnant, for sure.
That's why I thought that was one of those tests that they just do on mamas.
Okay, no more of it, please.
It's like, I'm done.
Yeah, I was
So,
pretty
that-
sure they do that, cause it used to be like a whole big thing, you had to like have consent signed to do an HIV test, and now we're like, no, we just do it.
Go ahead and do this one.
So the mom stays on art therapy during pregnancy?
Yes, art therapy is safe for pregnancy. Actually recommended for pregnancy so that baby's protected. Let's see, does it cause side effects? Of course, it's a drug, it all causes side effects.
Sorry, you said even if they're treated, no breastfeeding.
Yeah, no breastfeeding. We don't want any more of mama's cells to get to baby. Side effects, there's really nothing super jumpy outy here with side effects. It's all kind of random. Hey, you're taking a pill for something, these things could happen. It's kind of some nausea, dry mouth, things like that. It can cause some liver and some kidney dysfunction, so we do want to watch out. Liver and kidney, just get those tested every once in a while, especially if you start having any symptoms. It can cause some blood sugar kind of highs and lows. We want to keep an eye on that. But really nothing that we're like, hey, this is a big concern with HIV therapy. It's just kind of like those random nausea, vomiting, fatigue kind of type side effects. The biggest thing with HIV, with art therapy, is the drug resistance. We talked about this last week. You have to take it or that virus is going to mutate super fast, and then those drugs won't work, and then we have to try a new drug. Art therapy is a combo of a minimum 2 different drugs, sometimes up to 3 or 4 different drugs in a combo therapy. And we have a lot of different drugs. That's why I don't want you to know drug names or even the drug classes, because it just, if you take your therapy and then you stop taking it for whatever reason, you're gonna have to get swapped to a whole new therapy, and it may be completely different. So I'm not worried about you guys knowing the names of the drugs. It's just art therapy. Alright, so with art therapy, we're gonna go to PrEP and PEP. You guys have seen the commercials for PrEP, right? All the ads for PrEP. Alright, if you don't, y'all don't watch TV enough. Alright, PrEP. PrEP is a highly effective way of preventing HIV. PrEP is a small dose of art therapy, so just a very tiny dose of it. And it is for anyone who has these types of things. So maybe they've had a bad night where they made a poor decision and didn't have protected sex. They had some unprotected sex. They have a partner that they know is HIV positive. Even with protection, it's still a risk. Or if they've been diagnosed with an STD in the past 6 months. So obviously some protection didn't help them in that case. So these are people who PrEP is appropriate for. I'm sorry, I said that wrong. These are people who have habitual patterns that want to prevent more than just protection. Y'all know what I mean. Or if you share needles, so people who want just have a little bit more protection. So PrEP, prophylactic, preventing. And then we have, well, let me say this, with PrEP, it can be pills, it can be shots, Truvada, Descovy, those are the commercials y'all seen, or ads y'all seen on TV. Haven't seen those yet on ads. Those are new. Is it safe? Yes. It doesn't have very many side effects. Nausea, some diarrhea. I mean, not anything that you would say like, oh, this is a super bad side effect. How do you get PrEP? Go to the health department. All right. PEP, post-exposure. This is the people who have had a bad night, maybe made a bad decision. So post-exposure, I said it wrong at first. PrEP is for people who have habitual bad habits. PEP is for people who made a bad decision and need some protection. This is like your rape victims, your people that went out and got drunk or drugged and had unprotected sex. Your healthcare workers that got stuck by a needle. So these are for those people. So, and they actually sit there and go through each type of situation of where it may be appropriate. The biggest thing with PEP is that if you have an exposure, so if you got stuck with a needle at work and you know this person's HIV positive, you have 72 hours to go start your post-exposure prophylaxis or your PEP. After 72 hours, it's not going to work.
So it's like a plan B, just for.
Yeah, it's a plan B for HIV. You got it. Good job.
So is it just one time?
Yeah, it's like a month. I think it said a 28-day. Yeah, 28-day course of
Oh,
medicine.
you take a 1 pill a day for 20
Yep.
days.
Yep. So it's take a after exposure, 72 hour within the 72-hour time frame, you take this course of medication to prevent you from getting HIV. So
PEP, plan B.
there you go.
Plan B, PrEP, habitual decision.
Yeah, PrEP is for your habitual, or even with PrEP, let's say you have a long-term monogamous relationship with somebody who has HIV. So If you would like a little bit more protection than just condom usage, then your partner can take PrEP to try and prevent transmission. If the partner stays on ART therapy and is undetectable, they're not going to transmit it, but the partner may want to take PrEP just in case they flare up or they can't take their medicines or something like that. So it's all about just what's right for each individual.
And prep would be how many days or just?
PrEP would be like for like however long you would like to have sexual relations with
So
people
it's
that
just the
may be
same as
HIV
our-
positive or multiple partners, stuff like that.
Okay.
So PrEP's for as long as you're living in that lifestyle where you may be at a higher risk than other people.
So with the PrEP, it's saying it's a 28-day course. So if you have a partner, do you just, on the 29th day, you just start a new
So
course?
PEP is not meant, because this is a little bit stronger than PrEP is. So
Okay.
PEP is not meant to be taken multiple times. Like
Okay.
this is literally meant for something happened. Like kind of the two biggest things that I think of when I think of PEP, this is like for a rape victim or a needle stick.
Okay.
Like something happened
Okay.
and I need protection.
Okay.
Anything else, like if you are living in a lifestyle where you have multiple sexual partners or habitually have unprotected sex, that's a PrEP person. Like you need just, however long you're gonna make those decisions, you need daily protection.
Okay.
So, but this is more a singular event happened, I need protection. Alright, so that's art therapy, PrEP, PEP. Let's see what else we have.
So is it 2 pills every day for PrEP and then 1 pill every day for 28 days?
I'm not saying 1 or 2 pills, this is a treatment. So it can be an injection, it can be 1 pill, it can be 2 pills, like that, I'm not going into that. It's just, it's labeled as art therapy, it's labeled as PrEP, and it's labeled as PEP. So, but it could be injection, like they're really doing a lot with injections, especially with the art therapy, they're doing a lot of, like you can take an injection for a month. They actually just started doing the 2-month-long injections for PrEP, so I wouldn't get caught up in that kind of stuff, because that's changing a lot.
Are you cold by chance?
Not cold,
It's like Antarctica.
It is
Yeah,
chilly. It's
we're pretty
chilly.
cold.
You just got to fan.
I have a fan on.
Oh, okay, okay. We're good, we're good.
I don't know why, well, actually, I probably do know why, because nothing's safe in my body for 48 hours, so I just take my estrogen. Is that all I want to talk about with HIV? Let me see if I'm done with HIV. I think I'm done with HIV. Yeah, we've talked about all the HIV stuff. Okay. So that's all, do you have any more questions about HIV and AIDS? Okay. I don't have much left.
So it's part of me over there.
Okay, let's do RA and SLE or lupus real quick, because it's so small. So there's only 3 things left, so let me get these 2 done, we'll take a break, then we'll finish up with allergies. So, our 2 autoimmune diseases, because you guys have already covered so much of this content last week because we did all the medications, this is just super short. So our autoimmune diseases are lupus and rheumatic arthritis. So lupus, autoimmune disease that affects connective tissue. Where is your connective tissue in your body? Everywhere. So the signs and symptoms of lupus are quite extensive. Everywhere. So not every person's lupus looks the same. So lupus can look different from years old. And I was like, oh my gosh, why are her kidneys shut down this bad, 24 years old? Lupus. She had no other symptoms. We have a lady right now in clinical that we took care of on Monday. It affected her brain. She had lupus encephalopathy, and she just quit breathing. So she had to be put on a ventilator, and now she's got a trach because it's an autoimmune disease. We don't heal from autoimmune diseases quickly. So she's very slow to recover. So we got a lot of trach suctioning done at clinical though, so good practice for my students. So every person's lupus looks a little bit different. So it's an autoimmune disease that affects the connective tissue, which means it can affect any organ and it can completely and utterly shut it down. When we talk about just generalized lupus symptoms that kind of everybody tends to have, this little butterfly rash is pretty common across the face. And then fatigue. Fatigue is the most common symptom of lupus. Just like any other autoimmune disease, it has exacerbations and remissions. So what do you think exacerbates lupus? Sickness. The weird one is UV light. So stress, sickness, those things that you typically think of with autoimmune diseases gets triggered, but the one kind of weird one with lupus is UV light. So they don't need to be exposed to the sun. Now, I didn't say heat. They can be hot, but it's exposure to the sun. So they really need to try and protect themselves from the sun, wear the wide brim hats, wear the sun sleeves, try and stay in the shade as much as possible because that can trigger their lupus. This does affect our young ladies more than any other age group, so like women in their 20s is kind of the most common. When you're at your healthiest, yep.
How do we diagnose lupus?
So diagnosis with any autoimmune disease is super fun because you get misdiagnosed a whole bunch of times because there's no lupus test. So it's mainly over a period of time testing to see we're ruling other stuff out, and that's kind of what we're left with. So just like with multiple sclerosis, there's really no multiple sclerosis test. Just over time we see that these are symptoms that we're seeing, and so we get diagnosed with lupus. Treatments, we talked about the treatments. So the DMARDs, immunosuppression is the main treatment for lupus. And we already talked about everything we need to know about that treatment regimen, and that's the main thing. So that's why I said there's really not much to lupus because you guys already did the majority of it last week when we did meds. It's just people with lupus, their progression, you may have somebody with lupus that basically has no symptoms and they're just a little bit tired, all the way to the girl I had that had complete kidney failure shutdown. This also can affect cardiac, so I was trying to see where the cardiac stuff was. So we definitely always worry about with heart and lungs, because that can be one of the things that really shortens their lifespan with heart and lungs. Alright. Our next one is rheumatoid arthritis. I just like these little skeletons. I thought they were cute. On trying to differentiate between rheumatoid arthritis and osteoarthritis, because there are two very different things. Rheumatoid arthritis is our autoimmune disease that causes overall joint stiffness. So if you look at this picture right here, this is a normal healthy joint, and then as you go through, this joint starts to have a little bit of swelling, so there's really not much difference in these two pictures. However, when you get down to stage 3, the bones start being destroyed. Stage 4, connective tissue starts putting the bones together. And then stage 5, we just have the bones are connected. There's no joint anymore, which means that joint doesn't move. So this is the progression of rheumatoid arthritis. So the joint capsule actually starts breaking down and the bones eventually fuse together. So obviously we want to prevent this. So our treatment is same thing we did last time. The DIMARDs, NSAIDs, corticosteroids. Those are our treatments to try and stop this progression. So I'm gonna go back up to the diseases up here. So rheumatoid arthritis, the first symptom that people start seeing is their joints are very stiff right when they wake up in the morning. So the joints haven't moved while they've been asleep, and they become very stiff and very painful. So it's extremely important for these folks in the morning to do their exercises, to stretch all of their joints out and get them moving. It may be very painful, but if they don't do it, the pain's going to persist throughout the rest of the day. If they get up and move their joints around, hopefully within an hour, they should feel a little bit better. Osteoarthritis is very different because this is just, as we get older, the cartilage starts to break down in our joints, and so it's just a degenerative disease. So with osteoarthritis, we just have to do exercise. There's no treatment. They don't do like all the steroids and the NSAIDs and all of that for osteoarthritis. So all that treatment is just rheumatoid. And you guys went over all this last week. So there's really not much of any treatment that I need to go over, because that's for both. I put RA only, but that's because that's for, it's not osteoarthritis. The treatments up here, those can be for osteo or rheumatoid, but rheumatoid is the one where we do the DIMARDs. Alright, questions on rheumatoid or lupus? I told you it's not very much. Alright, break, we're gonna do allergies and be done. Alright, so let's finish up. So Ms. Hildreth said she's gonna do the benchmark at 1. So y'all come back at 1 for the benchmark. So go get you some food and then benchmark at 1. You mean 12? She said 1. I said I said the goal. We're scheduled till 2, 3. What are we scheduled to? 3 today? 12. For me it is. I'll go back home and lay down. Okay. Normally, I go through this whole VSIM with y'all. I don't feel like it. So, I highly recommend doing Kenneth Bronson VSIM. He's got great questions on the pre-sim. And then on the actual VSIM, if you'll let it go for a little bit, he gets real bad. It's quite interesting. Just kind of wait for a little bit and just watch it deteriorate as you go through. I don't think you can actually kill Kenneth. Like, there's some, like if y'all do Carl Shapiro's gonna die every time. Like, he don't survive. So, just, I can FYI you on that one. But, I don't think Kenneth will die. I've never given him long enough to actually see if he'll die. I'll actually do the interventions and keep him alive. So, did you let it just roll?
Yes, it was. I was freaking out at first because it was like, what went wrong?
Yeah.
He doesn't.
Okay.
So I felt better.
I mean, I've let him get pretty bad. Like, his heart rate was like 160 and his stat was like 82 or something like that. And I was like, well, I guess let me throw some oxygen on you. And the post-simulation quiz, he's got a lot of really good questions. So the pre-simulation quiz questions are pretty easy, a little detailed, but they're pretty easy. And the post-simulation quiz questions are really good. So I do highly recommend going through and doing Kenneth Bronson. So I like old Kenneth. He's a really good for really good practice for allergies. So, but there, that's all I'm doing with that. Okay. At least if I'm freezing y'all out, you can't go to sleep.
I could.
Is
that a challenge? I dare you.
Challenge.
Alright, allergies. Alright, so there's, actually our content says hypersensitivities. So hypersensitivities, there are 4 different categories. And I loved this picture because it kind of tells you what cell it affects. So when you think of allergies, you think of type 1. Type 1 are allergies. They're mediated by IgE. Worst case scenario, anaphylaxis. But this also is going to include like your allergic rhinitis, your eczema, your asthma, like all those types of things. But worst case scenario is anaphylaxis. So all those things that I said before, like your allergic rhinitis, your eczema, those are going to be localized allergic reactions. So like hives and wheals, stuff like that. Like if a cat rubs up against me, my skin's gonna break out. So that's a local allergic reaction. Anaphylaxis is a systemic allergic reaction. So we're gonna get into that one in just a second. Type 2, this is gonna be like your hemolytic anemia. This one we don't see too terribly often, but this is where we have a lot of cell rupture. Think of it like your blood transfusion reactions where your cells just start kind of destroying each other. So we don't see this one too often. Type 3, this one basically includes all of your autoimmune diseases. So type 3 is autoimmune diseases. Type 4, this one is also called delayed. So if you want to write the word delayed, that kind of helps me remember what it is. This is where something pops up days to weeks after an exposure. So this is like your poison ivy. Like we all have a reaction to poison ivy. You don't have to be allergic to it to have a reaction to it. But you have a hypersensitivity to it. So it's going to occur days to weeks after. So rash down here, just think poison ivy. This is also where we do like our TB skin test. Like if you're gonna have a reaction to it, it'll be a couple days later. So anything that's delayed, the Stevens-Johnson syndrome, the SJS, a couple of days after you get exposed to an antibiotic. So type 1, this is what we think about with allergies. Type 2, rarely ever see. Type 3, all of our autoimmune diseases. Type 4, delayed, all those things that take a couple days to happen. So we're going to get into the main focus on our test will be type 1 because out of all these things, I'm not going to focus at all on type 2 because it's so rare that we see it. Type 3, we've got lupus and rheumatoid arthritis as our examples. Type 4, you guys know about poison ivy, so we're not going to talk about that. So we're mainly going to talk about allergic reactions. So you see all these are hives and wheals. What's this poor little baby right here suffering from? Angioedema, little swollen face and lips. Out of all these, the most dangerous one is angioedema because I'm worried about his airway. So when we have allergies, so we've got a couple of different treatment options. Let's see where I'm at. Yeah. So over-the-counter options. So we're not talking about anaphylaxis yet. We're just talking about allergies in general. So you guys know all the over-the-counter things you can get for allergies, all the antihistamines, the Flonase, like the little steroid nasal treatments. They've even now have Singular, where you got the anti-leukotrienes that they have out now. So a lot of different over-the-counter choices, prescription choices. Honestly, a lot of these have gone over the counter now for a lot of the allergy symptoms as well. But main thing with allergies is we want to try and limit our exposure to them. knowing good and well that's not always the case. So if you are allergic to, let's say, shellfish. So one of my friends has a shellfish allergy, and she's so sensitive that if something is, like if she has French fries, she asks every single restaurant, do you fry shrimp in the same fryer that you fry the fries? And if they say yes, she won't eat anything that's been fried there.
Try asking that 3 times fast.
Blah, blah, blah. I can barely talk as it is, so I'm just happy I'm here. So, we can't always prevent exposure to our allergen, is my point there. So, we try to avoid it as much as we can, but we always got to be prepared for if you're exposed, how to handle it. Desensitization options, this is the allergy shots. So, allergy shots, the way that we do that is you come in and get allergy tested, which is super fun. Who's been allergy tested? It's like, really? Is it just us? There's like 4 of us? Oh my gosh.
Not really.
So, it's super fun where you get the sticks up and down your arm to all the common allergies, and then they go down the back of your arm. They did your back, they did my arms. They did my daughter, they did her back. She was little, so she can't scratch them. It's like getting bit by 64 mosquitoes. It's really fun. So just so we all know, I'm allergic to the earth God created except for one tree. Just the one. Allergic to everything else. So it's great. But we do those allergy tests, and to get the allergy shots, they mix up a little combo of things you are allergic to and create your very own medication tailored to what you are allergic to. So you cannot take my allergy shot, and I cannot take your allergy shot. So if that's a route that they want to go down. So with the allergy shots, patients have to come in, have the shot done in the office, and then have to stick around for 30 minutes because we want to give you just enough of an exposure to your allergen to maybe cause an anaphylactic reaction. So we have all the equipment there to save you if it occurs. We don't want to cause it, but we want to trigger your immune system to work because we're trying to override the bad cells with the good cells. So IgE is what's being triggered with an allergen. We're trying to override and get that IgG and IgM to come in and take over and basically tell IgE to shut up and go away. We're good. Like, we've got this. So that's the whole point of allergies. We're trying to expose you to the point those bad cells are like, no, we're good. With little kids, so some of you may have kids or have friends who have kids that have a milk and egg allergy. It's extremely common milk and egg allergy for little ones. And they'll tell you to give them little tiny bits of milk or little tiny bits of eggs every day and gradually increase. And that's, again, a desensitization option. You're trying to give them small exposures to have them eventually overcome those allergies.
One thing that my friend did that I thought was pretty smart, you know, when you're introducing new foods to your kid, she went ahead and introduced peanut butter on the way to her appointment for his checkup.
So just in case.
Just in case. So if he started having a reaction, we would
They're
be
there.
in the pediatrician's office.
It's a pretty good idea. So desensitization is going to be your exposure therapy. So it can either be done through, especially if it's food allergies, can be done that way. As long as it's safe, if somebody has a true nut allergy, that desensitization with exposure may not be a good choice. We don't want to send them into anaphylaxis. So desensitization is always going to be done with a healthcare provider supervision, not just something you do on your own. So worst case scenario, we'll see. Is that all I'm going to say about anything before I do allergy anaphylaxis? Yeah, we're good with that. So anaphylaxis. Do I have a slide for it? I do not. All right. So this is where I usually do Kenneth Bronson, so that's why I don't have slides for it. So anaphylaxis, it's going to be a systemic allergic response. So that will be full body vasodilation, which will do what to your vital signs? Yeah. So your blood pressure will go which way, up or down?
Down.
Down. And then your heart rate will go which way, up or down? Up. So you'll have hypotension and severe tachycardia because of the massive full body vasodilation. And then you will have laryngospasm. So your airway will constrict while your blood vessels open up massively. So you can't breathe, and then your blood pressure's extremely low. All right, so if you have someone that goes into, so we already talked about EpiPens, so we're gonna go ahead and put that content in here. So this is why we did the whole med board on EpiPen. So if someone starts to experience anaphylaxis, if they have an EpiPen, they should use it immediately. And if they're unable to use it, hopefully they can communicate enough with you to know you should use their EpiPen immediately. And we've got the little picture there, everything that we learned about it last week. Blue to the sky, orange to the thigh, stab them as soon as possible. So if they come into the hospital, so like Kenneth Bronson, he has an allergic reaction to his antibiotic. So with Kenneth Bronson, since he got an antibiotic and he starts to say, help, I can't breathe, what should you do on that VSIM or with the patient in real life? If you started an antibiotic and they suddenly go, I can't breathe, what should you do? Stop the antibiotic. Yeah. Stop the exposure to the allergen. Because honestly, this is where we're going to see it in the hospital the most, is going to be those, maybe a person who's never gotten an antibiotic before, like you ask them, do you have any allergies? And they say no, but maybe they've never had a sulfa drug before. And now sulfa drug's the second most common allergy. You give them a sulfa drug and they go into an anaphylactic response. So that's where you guys are going to see this the most common situation. So we'll stop the antibiotic, and then what am I going to do? I heard y'all say it. Yeah, I'm going to sit them up while they can breathe, while also doing a lot of assessments. So what assessments need to be done quickly? What's their O2 stat? Like a whole set of vital signs, right? So we said tachycardia, hypotension. What else do I need to assess really quick? Lung sounds. Because what lung sounds do I expect with an allergic reaction? Wheezing. So I should very quickly, after I've determined, yep, we're having an anaphylactic response, I need to call the healthcare provider. Probably at this point in time, I've called a rapid response if we're on the floor. But if I'm in an ICU or an ER, guess what? We don't have one of those. So I just, because we're there, it's us. So I'm going to call the healthcare provider at this point. What kind of medications do I need for this person? I need Epi. So we're going to give Epi just like, so we can do this just like the EpiPen, or we can give an IV under controlled situation in the hospital if I've got an IV access. But we don't typically, we still like the IM Epi injection. They gave my mom Epi IV in the ER and almost killed her because they gave her too high of a dose because it's extremely, for some reason, Epi comes in 2 different concentrations and it's just a 10,000 and 1,000 look really the same when you're in a high adrenaline situation. And there's no bright colors to like differentiate which one. And they grabbed 10,000 instead of 1,000 and gave it IV and almost killed her. I never saw that nurse again. I'm sure she was probably in the bathroom crying for a long time because that was very scary because she didn't have a med error. So typically we're still going to give IM Epi in the hospital because it is safer and we have all this equipment in the hospital anyway. So we're going to give Epi. What other drugs can we give for this person? So it's not all the only drugs we're going to do. Antihistamine, so we can give Benadryl IV. What else? So we can give fluids because if your blood pressure is low and your heart rate is high, I can give fluids to help with that blood pressure. What else? Some massive inflammatory process. There we go, steroids. So I can give epi as my first round treatment, because epi is going to open that airway and close down those vessels. So epi is my first line treatment, but after that, we have antihistamines, corticosteroids, we have fluids. There's no really like which one's first, second, third in that. It's just kind of all the things. Epi is definitely first choice. If the patient is still struggling, we may have to do more than one. Yeah, we're going to give epi however many times we need to give epi for my patient to be safe. This is why they do this outside of the hospital. They need to come to the hospital because I have all the epi in the world in the hospital. When they can breathe.
Okay.
Yeah, when I stop hearing wheezing, when their blood pressure improves, when their heart rate improves. Yeah, it's just, epi has a very short half-life, so it's going to be out of your system a lot faster than depending on what allergy you have. Like if you ate a whole bunch of peanuts not knowing that peanuts were in there, that might stay in your system a lot longer than the epi does in order for it to get out. So we got to watch it. Like Kenneth Bronson, he recovers pretty quick because he just got a touch of that antibiotic before you stopped it. So he didn't get a long exposure to his allergen. All right, so antihistamines, fluids, corticosteroids. Tell me about the oxygen. Are we going to give them oxygen?
Yeah.
What kind? All right, so the textbook reads high flow oxygen. So what mask are you going to get? Because this little 2 liters nasal cannula is not it for an allergic anaphylactic response. So what kind of mask are you going to get to provide high flow oxygen? The one with the bag, the non-rebreather. So it's called a 100% non-rebreather. At Grandview, we have these things called oxidizer masks that also can, I don't like those. 100% non-rebreather, the one with the bag. Okay, so you have gotten the 100% non-rebreather and you have put it on the patient and you have hooked it up to the flow meter. What liter amount are you going to turn on the flow meter? It's called a 100% non-rebreather. So what are you going to turn the flow meter onto? The highest it'll go, all the way up. It's called a 100% non-rebreather. So crank it up as high as it will go. So when we have somebody with a narrowed airway, I want to make sure I get them as much oxygen as I can through the narrowed airway. And then I will start to turn it down as their wheezing improves and their airway starts to open up. So this is the opposite of the least invasive. We're going to just crank it up. Yeah, I usually do Kenneth. Let's see. Orders is Kenneth. Kenneth's got some albuterol too on his orders. So yeah, we can do breathing treatments as well because that'll open up the airway. Albuterol, Atrovent. If their airway is still closing down, we actually can give epinephrine as a breathing treatment as well. So it's called racemic epi, race, M-I-C. So it's literally you put epinephrine in a breathing treatment and it will open up the airways. We typically don't have to do that if we're giving an EpiPen already. So if we're already given epinephrine, we typically don't have to do it in a breathing treatment, but it is an option. It's something that you can do. I've seen it given just a handful of times, and it's for like some really weird kind of like tracheal stenosis type situations. But it is an option that can be given. All right, what questions do we have about allergy? Typically I do Kenneth, which takes up like an hour. That went really fast, but not doing the decent. Alright, what questions do we have about anything? Lupus, arthritis, HIV,